Treatment of an artificial midshaft clavicle fracture by Professor Dr. Rainer Meffert, Würzburg, Germany. Fracture classification. This case shows an artificial AOC3 complex midshaft fracture with a longitudinal bone split laterally on a specimen. Surgical approach and fracture preparation. A transverse approach has been chosen. The skin and soft tissues are divided to expose the fracture formation for the midshaft of the clavicle. During dissection and cleaning of the fracture gap, the midshaft defect becomes visible. In this particular case, the midshaft fracture comes with an additional longitudinal split fracture, which needs to be reduced and fixated first before plating can be considered. As the split fragment is completely separated from the clavicle shaft, the precise reduction of this fragment will be a necessary step prior to plating. Reduction in this case is performed by utilizing crab claw reduction forceps. Aligning the fragment anatomically, 2 set screws are placed on either end of the fragment. This measure reduces the complexity of the fracture for the subsequent plate osteosynthesis. Plate selection and reduction of the fracture. Per side, there are 6 different superior shaft plates to choose from. There is one short plate with 6 holes. The most commonly used 8-hole plate comes with 3 different curvatures. 10 and 12-hole plates come with 1 curvature only. The appropriate clavicle plate is selected, in this case a superior midshaft plate with 12 holes. As the plate fits the clavicle very well, bending is not required here. For preliminary fixation, 1.6 mm olive K wires are used. Also, for easy pre-reduction, double-pointed reduction forceps can be utilized. Here, the dimples between the screw holes become very handy as the surface of the implant doesn't get damaged by the holding instrument. A second olive K wire leads to a secure position of the plate on the clavicle. The plate sits now flat on the bone, leading to an anatomical reduction. Plate fixation. Using the single striped core hole drill bit, a golden screw is placed through the central part of the longitudinal slot on the lateral aspect of the fracture. This is followed by a TriLock screw in the most lateral screw hole. After removal of the lateral K-wires, all screw holes laterally are filled with TriLock screws. Now a golden screw is inserted through the medial longitudinal slot, and one of the 2 olive K-wires can be removed. For anatomical reduction, TriLock Plus has proven to be a helpful means. TriLock Plus allows to first create an axial traction or compression before the locking screw eventually engages in the locking part of the hole. An eccentric core hole is drilled through the TriLock Plus hole with the arrow of both the drill guide and the TriLock Plus hole pointing towards the fracture gap. After defining the screw length, a TriLock screw is inserted until the screw head just makes contact with the plate surface. After removal of the olive K-wire, the golden cortical screw in the longitudinal slot can be slightly loosened. Now the TriLock screw is fully tightened, and the lateral part of the clavicle is pulled towards medial by the effect of the golden TriLock plus hole. To fully secure the construct, the golden screw in the longitudinal slot is retightened. As the cortex of the clavicle shaft can be very dense and hard, it sometimes can be advisable to pre-tap the drill hole prior to screw insertion. For those cases, a tapping instrument is provided in the set. This measure reduces the insertion torque and the implant screw significantly. Filling additional screw holes with TriLock screws finalizes the plate fixation. A final control shows the anatomical reduction of the fracture, with the plate being placed centrally over the transverse fracture. Postoperative X-Ray. The X-ray shows a stable reduced clavicle despite the large central shaft defect.